overlooked factor that can extensively impact mental, physical, and emotional health. Research is being conducted on how we can optimize our health naturally through what we put into our bodies. And this research can also open the door to holistic health methods and being able to steer away from prescription drug solutions.
Our research study is important because many symptoms relating to poor health are caused by nutrient-deficient diet. This is an important issue, especially within the Parkinson's disease community, because of the effect a healthy, balanced diet can have on the severity of symptoms. The purpose of our research study is to examine how we can improve people's overall health through nutritional intake. We chose to have individuals track their vegetables to improve their nutritional intake.
Our hypothesis was individuals who participate in our study will experience lower levels of physical pain, improved overall health, improved mental and academic health, improved sleep quality, and higher energy levels through adding more vegetables to their diet. Our participant recruitment and characteristics were peers and mentors from the neurophysiology lab, and we recruited them through announcements in lab meetings, such as verbal announcements and follow-up emails. And we had no inclusion or exclusion criteria, and all volunteers were accepted. For our methodology, participants will fill out a 5-question survey rating various factors of their health from 1 poor to 10 exceptional. And those factors of their health are how much physical pain they typically feel, how is their overall emotional health, how is their overall mental and academic health, what is their typical energy level, and how is their sleep quality. Participants will then alter their diet for a week by adding an additional half a cup of vegetables to each meal, and they'll track their additional vegetable intake on a corresponding spreadsheet for accountability. And once participants have completed this cycle for 7 days, they'll once again take the same survey that they did at the beginning so that we can track the improvements of adding half a cup of vegetables to each meal.
So for our data collection, essentially what we did is we took their initial survey that we sent out and had them record all the 5 different things that Leah mentioned before, such as, your physical health, your mental health, those things. That's what the initial survey measured. And then we gave them a score out of 50 and found the average of those scores for all the people who took the first survey. And then after that, once they took the first survey, we just sent out a spreadsheet so that they could monitor how many meals that they included vegetables and how many meals they did not. And then finally, we sent out the sheet again to everyone who finished all 7 days, and then found the scores for the second survey and found the averages of those as well. And then these 2 charts, our first one shows our initial versus the final health assessment scores for all 4 participants who did the initial survey, as well as finished all 7 days of the of eating the half cup of vegetables, and then completed the final survey as well. And as you can see here, it looks like we have an improvement as their scores out of 50 for all 4 of the participants did improve. And then if you look at our average scores, they also improved. So those are those 2 charts. But then what we ended up finding out is that we could not determine any statistical significance because our p-value was too low after we collected all our data and ran our t-tests and combined all the scores and such. And once we analyzed the overall improvement that we saw, we found that it was not actually statistically significant. And you can go to the next slide. So what our p-value actually was about 0.11, and to be significant, it needs to be, I believe, about 0.5. So since it was not statistically significant, we cannot definitively determine whether or not our final average was actually an improvement from the initial our initial survey, or if it was just like an anomaly. Oh my goodness, I'm sorry, I cannot speak right now. But then after talking to Dr. Stegemuller and then looking at our results again, we found that maybe if we had taken more data from more people, our p-value would have been significant since we did have such a small sample size. Our results very well could have been significant or actually meant something, but it's hard to say since we had such a small sample size, and also since the survey or our experiment only lasted a week.
We expected that increasing vegetable consumption and therefore nutrient consumption, participants' mental, physical, and emotional health would improve. However, we may find limitations in the improvements due to the limited time of the study, the minor and insignificant change in diet, and other nutritional factors that are present in a participant's life. For the future direction of our project, we hope to move forward and begin to apply our experiment to individuals with Parkinson's disease. We would like to research the positive effects a nutrient-rich diet has on symptoms associated with Parkinson's disease. We are also interested in seeing what types of foods are most effective in reducing these mental and physical symptoms.
So these were some of the references that we used, and are there any questions?
Any questions? You can always also put it in the chat and I can ask those questions for you to the group. Or if you don't have any questions, then our group did really well and we can move on to our second group. Okay, so I don't see anyone's coming in, but I'll keep an eye on that. For our second group, whenever you are ready, you can start sharing your screen.
Can everyone see my screen?
Yes.
Awesome. So I'm Haley Negley.
I'm Bellamy, guys.
And I'm Eric Drawley.
And our research is the effects of mobile app interventions on working memory and verbal fluency.
All right, so to get started with, we'll go a little bit into the background information that was sort of guiding our study as we went along. So from our journal review, we found that long-term musical interventions have been shown to have significant effects before. From this Finnish study on a group of older adults with dementia, we found that there were significant improvements in orientation, short-term and working memory, and just general cognition. In addition, they also saw improvements in scores on tests relating to measures of depression and quality of life with both the participants of the study and with the caregivers. So this kind of gave us an idea that by integrating this musical aspect of the intervention, we could transfer it to something else. In addition, we also wanted to bring a little bit in of the language learning aspect, but this wasn't something that we saw as much in our journal review, so we wanted to explore any impacts that a similar intervention could have. So in designing our study, we used two mobile applications, both which are relatively popular. The first was Duolingo, which is a mobile language learning application that teaches users and reinforces their language skills in a language that they choose. This works well because it's very personalized to the individual user's strengths and weaknesses, allowing them to really target things and improve on things that they need to improve on. We also used an app for ear training, which we chose because it was roughly analogous to Duolingo. It was called Perfect Ear, which allows the user to practice different musical skills like scales, intervals, and sight reading to enhance their musical skills and their musical ear. We chose Perfect Ear, as I mentioned, because it was analogous to Duolingo. It had a similar personalized feel and sort of a course-based structure. So from this background information, we came up with our central research question. What are the effects of a language learning and ear training intervention on working memory and verbal fluency? So to work with this research question, we had three main purposes: to determine whether either intervention had a statistically significant effect on working memory and verbal fluency. That is, to see if either intervention had an effect that was significant on its own. To determine whether any individual intervention had a bigger effect than the other, to see if there's any differences between the two. and to postulate future directions of research in the case that significant differences are found in either of the interventions.
So our hypothesis was that the two interventions would have equivalent positive effects on at least one of the cognitive functions. The way we got to test our hypothesis is in our methods. We began with a demographic survey that collected data about our participants, such as sex, age, and we also inquired about previous musical experience and if they were fluent in any other languages, which might interfere with the language intervention, and any previous musical experience may change the effects that a music intervention would have. So after we had the survey, we followed up with an email, and then they signed up to take our pre-tests. It was a battery of cognitive tests, including 2 verbal fluency tests and 1 memory test. The first verbal fluency test included naming as many animals as you could in 1 minute. The second verbal fluency test was naming as many words as you could come up with that began with a certain letter. And then our memory test that came in the middle was a backward digit span. So we said 1, 2, 3, 4, and asked the participants to repeat it backwards to us afterwards, 4, 3, 2, 1, and so on. After the cognitive tests, we randomized them into 2 groups, and they began the intervention. We asked them to do 15 minutes every day on either the Duolingo intervention or the music intervention, and keep a journal recording any deviance or difficulties they had during the 15 minutes. And then approximately 7 days later, they took a post-test that included the same cognitive tests with different prompts. So instead of animals, they named fruits and vegetables, and we used different numbers, and they named as many words as they could, starting with a different letter. For the demographics, our participants, we had 7 in total. 4 were in the ear training and 3 were in the language learning. We had many lovely ladies participating in this study, and we had 1 brave gentleman in our study. Our participants were recruited from our lab through emails, and the average age of our participants was 20 years old, so 18 to 21, a pretty young demographic. And there were participants who were already familiar with music, had been practicing, and were currently practicing a musical instrument, but none of our participants that finished were fluent in any other non-English language.
For our data, the dependent variables in our study were the change in specific cognitive functions. The independent variable was the type of intervention, so whether they did ear training versus language learning, and this was randomized. So it did not matter what the demographic survey said, we still randomized them no matter what. And then our constants in the study were the length of intervention, which was the time spent per day, the period of intervention, which was 1 week, and the type of cognitive tests that were used for the different cognitive functions. And then the data was analyzed by calculating standard errors and by completing both paired and unpaired t-tests to assess the significance of our results. So for our results, this is our first graph, which has statistical significance, and this is from our language group. And this compared the percentage of correct numbers that were said backwards between the pre and post test. This other graph is also statistically significant, and this was the amount of words that were said per minute, and this was for our singing group. And the one thing that we found that was interesting was that this had a downward trend and not an upward trend. And these are our comparisons of the differences for the same tests, but it compared the differences from pre to post for the singing group and the language group. And this is for the digit span test that tested working memory. And this is the graph for the second test that was for verbal fluency. and these were not statistically significant. For our discussion, we expected to see a positive effect on the specified cognitive functions after our interventions, but we only had 2 statistically significant results, and only one of them was a positive trend, while the other had a negative trend to it.
Some possible explanations for this include our limitations, which we'll discuss in a moment, as well as potentially fatigue in the testing process between the first and the third test. There could have been some mental fatigue that built up that was slowing people down a little bit, as well as potentially differences in difficulty between the different concepts and letters. For example, fruits and vegetables may be harder for people to conceive of than animals.
And to continue, we are going to discuss the limitations. So our participants were not all able to do the full intervention, and this had mostly to do with the limitations of the apps. So participants were not able to complete the 15 minutes on the apps because they would run out of hearts, or there were distractions or deviance just in their day that inhibited them from being able to complete the 15 minutes. Additionally, we had a pretty small sample size, as you saw, 7 participants total. So we believe that expanding that could help in showing us what the more potent effects could be. And also we had a short period. It was only a week, and we are unsure if we can make any proper judgments off such a short period of time. And in the future, I think that's next, we are hoping to, as I said, try with a larger sample size. With just more people will help us see more clearly if there are statistically significant differences between the interventions. We also would like to do a more in-depth intervention. We ask people to participate for 15 minutes on an app, and that the depth to that was not that great. So we would like to flesh out more the intervention so that it will have a greater effect. We also were hoping to see if there was a difference between using a mobile app and having an intervention in person, and in the future hope to, instead of having a mobile app, use an in-person intervention and do language training or music training face-to-face and see if that has any differences. And then also, we did not have a control group. So in the future, we definitely want to have a control group to compare to.
So our applications for people with Parkinson's.
Sorry for the interruption. You are over the time. You can wrap it up in 1 minute or 2. Will be great.
Okay. So we would like to use our research to see which intervention could be better for people with Parkinson's, and this could be used as possible treatments in the future. And we'd like to explore the differences in efficacy between mobile application and in-person classes, because we noticed during the COVID-19 pandemic that there was a slight increase in participation for our outreach in this lab. And possibly if the online treatments work just the same as an in-person, we could have more people use the treatments as well. And this is our works cited. Any questions?
Okay. Any questions for our second group? And again, you can utilize the chat.
Thanks so much for listening.
Okay, great job, everyone. Okay, well, if there's no questions, we can move on to our last presentation. And that's actually me.
Okay, I'm going to introduce Cassandra Diaz, who is a fifth-year neuroscience PhD student. She'll be presenting on the effect of Parkinsonian medication on inflammation in persons with Parkinson's disease. Go ahead, Cassandra, good luck.
Thank you. Can you all see my slides? Good.
Yes.
Okay, so today I want to present to you, this is actually what my dissertation project focused on for my PhD. And I just kind of want to give you a quick introduction for everyone. I know that we have in this particular presentations, individuals that from our community that have Parkinson's. So I just kind of wanted to introduce my project to everyone in case anyone wants to volunteer, be part of the project, and hopefully help me answer this question. And what I'm interested in looking at is the effect of anti-Parkinsonian medication on inflammation in Parkinson's disease. In particular, the medication that I'm looking at is the L-DOPA-levodopa combination. So just go into as to why I'm looking at this. So as a reminder, again, kind of what is Parkinson's. So Parkinson's disease is the second most common age-related neurodegenerative disorder worldwide. The average onset for Parkinson's is 60 years of age, but some individuals may develop Parkinson's a little bit earlier during their 30s or 40s. The clinical features usually associated with Parkinson's is the triad motor symptom, tremors, stiffness, and slow movement. A little bit of background as to why scientists as well as neurologists believe that these symptoms arise in persons with Parkinson's is due to the degeneration that happen in the substantia nigra in persons with Parkinson's. So it is believed that the symptoms onset can be largely attributed to the neural death that occurs within the dopamine producing cells in the substantia nigra. So here I'm kind of orientating you to that area. And this is kind of a diagram that shows what the substantia nigra looks in a healthy individuals versus what kind of it looks like in individuals that have Parkinson's. So it is believed that decrease in the production of dopamine producing neurons in this particular area lead to a decrease in signaling, and specifically to the signaling to the striatum. So this is kind of that other nuclei in the brain. And why this is important is because the striatum is a major nuclei of the basal ganglia that is involved in voluntary control, so movement. And it's because of this, this decrease in dopamine producing neuron, that therapeutic strategy for Parkinson's disease mainly focus on the increase of dopamine in this area. And that is why usually, like I said, the focus is to increase dopamine in the substantia nigra. However, we have an issue that dopamine itself is a big molecule that cannot cross the blood-brain barrier. And it's because of this that L-DOPA, which is a much smaller molecule, is prescribed to persons with Parkinson's. So L-DOPA is much smaller than dopamine, and L-DOPA can cross the blood-brain barrier. And once L-DOPA have reached the brain, there's an enzyme in the brain that can turn L-DOPA into dopamine. However, other research has pointed out to the fact that L-DOPA itself does not ameliorate all of the motor symptoms associated with Parkinson's. I'm not really sure if some of our individuals that are in the chat here have experienced this phenomenon where your medication don't necessarily lead to the improvement or a lot of the motor symptoms that you are suffering, but that's kind of what the literature is pointing out. And it's because of this discrepancy that a lot of research has started to look at other contribution, other factors that might be leading to PD pathophysiology as well as the disease progression. And one of those factors is inflammation. So while initially it was thought to be secondary phenomenon to the disease, there's evidence which suggests that an inflammatory response itself can be contributing to Parkinson's pathogenesis as well as disease progression. So these are just a few studies that I have cited here that has shown that there is alteration in inflammatory response in the brain, in the cerebrospinal fluid, and the periphery, and in the periphery nervous system in persons with PD. So this is kind of what the literature has shown. I myself have conducted some preliminary study in the lab, and the studies that we had done in the lab support this idea that when compared to healthy older adults, persons with Parkinson's have higher levels of inflammatory response. And this, how we're measuring here inflammatory response is through these proteins, which are known as cytokines. And what are cytokines? They are small proteins that are important in cell signaling. And when they are activated in your peripheral nervous system, they tell you information of the inflammatory response. So basically, what is your immune system doing in response to an invader, an assault, an infection, and so on and so forth. So when we look at that, so the black bar are individuals with Parkinson's, and the gray bar are healthy older adults. And throughout, we see that individuals with Parkinson's have a higher inflammatory response than healthy healthy older adults. And it's because of this that recent research has focused on inflammation as a biomarker for Parkinson's disease. So I guess Dr. Oken mentioned before, we always try to find biomarkers to early diagnosis of the disease that can lead to early treatment. And a line of research in the field focused on inflammation and what the immune system is doing. However, what we have found is that other mechanisms may also be contributing to the inflammatory response in persons with PD. And that's kind of what leads me to my dissertation and the work that I want to do in the lab. So it seems that L-DOPA treatment may be inducing an inflammatory response of its own in persons with Parkinson's disease. So what is the literature showing here? So there has actually been some studies, in particular 2 studies that has shown that exposure of peripheral blood molecular cells, and these are your periphery immune cells. So when you take these cells from persons with PD and you treat them in a petri dish, and you treat them with a medication, there seems to be an immunological alteration in those cells. And this itself leads scientists to believe that the medication is also leading to an inflammatory alteration in persons with PD. When we do the same, when I wanted to prove whether it was true in the lab, with this, we do see, so just kind of to orientate you to this graph here. So these were results that were obtained from studies conducted in Dr. Stegemoller's lab. So here we have the demographics. These are the cells from healthy older adults. Here there's 3 males and 1 female, and the age was about 62 years of age. And there were 3 individuals that identify as white or Caucasian, and 1 individual that identified as African-American or Black. So when we take the cells from those individuals, healthy older adults, and we treat them with different concentration of L-DOPA, what we see here is that the medication itself is leading to this inflammatory suppression. So the medication is leading to immune alteration in inflammation. And why is this important, you might ask? So as I said before, immunological alteration found in PD may be partially attributed to the treatment itself. And why is this important? Considering the long-term use of L-DOPA treatment and the role of inflammation in the pathophysiology and symptomology of PD, it is essential to evaluate the role of L-DOPA in mediating inflammation and how it correlates to the motor symptom. And the reason for this is, as I said before, a lot of scientists are trying to use inflammation and inflammatory markers as a marker for diagnosing Parkinson's disease and also potentially for the treatment of Parkinson's disease. However, if the medication itself is having an effect on the inflammatory response, then it's very problematic for us to say, oh, this inflammation that we are observing is due to the disease and not necessarily to the medication. So we need to be able to differentiate inflammation due to medication and inflammation due to disease. And it's because of this that the overarching goal for my project is to determine the role of L-DOPA treatment in eliciting a specific immunological response and its implication to the cardinal motor symptoms of Parkinson's. And the reason why I want to do the second part to see what is the relationship of the motor symptoms is, as I said earlier, the medication itself doesn't treat all the motor symptoms in persons with Parkinson's. So we want to see, okay, well, can these motor symptoms be associated to not necessarily just the dopamine being lost, but can inflammation be playing a role in the progression of this motor symptom and even maybe the onset of those motor symptoms? We good? So that's kind of, I gave you a lot of information there. So I'm going to stop here and say, is there any questions that anyone have at this point? Because then from here on, I'm just going to diverge a little bit into my methodology and how I will be collecting this data. So any questions? All right. So we'll move on to the next part. So who am I looking to recruit? So for my study, I'm looking to recruit 35 persons with PD and 35 age and gender match healthy older adults. What the inclusion criteria is for this. So for individuals with Parkinson's disease, you had to have a diagnosis of Parkinson's, a HOMA-YAR score of 2, needs to be on a stable regimen of anti-Parkinsonian and psychotropic medication for 30 days prior to participating in the study, be between the ages of 40 and 84. And this is very important, be able and willing to withdraw from your anti-Parkinsonian as well as any anti-inflammatory medications you're taking the morning that the study takes place. And the whole idea for this is that we want you to be off the medication so then we can take your cells and treat it with the medication ourselves so we can compare what that looks like, what the inflammatory response is as we manipulate them. For the exclusion criteria, so if you have a significant cognitive impairment, and this is as measured through the mini mental examination exam, so the MMSE, if you have any symptoms of depression, and all of this is because these two, so cognitive impairment as well as depression has been associated with inflammatory response. If there's any sign of infection, again, that's also associated with inflammation. If you have had a surgery within the last month, a vaccination within the last 3 weeks, or if you're on any medication that the washout period is longer than 24 hours. And finally, any immunosuppressant drugs within the last year. So obviously we want to see what the immune system is. And if you're in any immune suppressant medication, then that would be kind of hard for us to tell. So this is just kind of the general outline of the study. So on the morning of the data collection, we'll go through some informed consent. We'll collect some demographic information, age, gender, years of education. We'll do the MMSE, the BDI, as well as the PDQ-39. And then finally, to measure the symptoms like motor impairment, gait, and all of that, we'll also do the UPDRS-3. After that, since we're interested in looking at inflammation, a trained phlebotomist will do a blood draw. And this is so we're able to, again, to measure the inflammatory response. Then from there, individuals will take their dose 1.5 times their daily dose of their L-DOPA medication. And then they'll do a self-selected activity like reading a book for an hour. After that, we'll do the total UPDRS, and then we'll do a second blood draw. And the whole idea is that we want to do a blood draw when you're off medication, and then another blood draw when you're on medication, so we can compare the inflammatory response. And this is kind of how the study will look like for that. Yeah, at this point, that's kind of all I have. If you have any questions, please feel free to ask. Hopefully when the IRB here, Iowa State, allows me to start my data collection, you will be interested in participating so we can identify what's the role of medication and inflammation and how inflammation plays a role in Parkinson's disease. Again, thank you so much for listening.